Well, I'd like to thank SAGES and the organizers for the invitation. I've been tasked with talking about magnetic sphincter augmentation and the indications for evidence. These are my relevant disclosures, of which Torex Medical, I have a restricted research grant with those folks, so that's the most important one. This device, as you know, was approved by the FDA in 2012 and introduced in the United States after several trials, and we are now into the 5-year period, which has resulted in fairly balanced outcomes at 5 years with a relatively low PPI utilization rate after magnetic sphincter augmentation, reflux control now approaching Nissen fundoplication, the superior ability to belch and vomit after compared to Nissen, comparable quality of life with, on the other side, a consistent erosion rate of about 0.15%, a reoperative intervention rate about 3%, and dysphagia rates, which is one of the highest cited problems, but when compared to Nissen is very similar. The indications for these 5-year results were this. In the FDA brochure, it was indicated for patients diagnosed with gastroesophageal reflux disease defined by abnormal pH testing who had chronic GERD symptoms despite maximal medical therapy for the treatment of reflux. The only contraindication that was listed was a known or suspected allergy to titanium, stainless steel, nickel, or iron, and potentially the need for a 0.7 Tesla MRI, which as you know now is 1.5 Tesla. There were associated cautions for use with this device since it had not been evaluated in hernias larger than 3 centimeters, patients with visible Barrett's esophagus, advanced esophagitis, and major motility disorders. There are a long list of additional precautions for use, which I think most foregut surgeons would look at and say, well, that seems all reasonable. There was no data behind them, but it all seemed reasonable to sort of be cautious in these particular sets of patients. And over time, those cautions really became sort of what people assumed were the indications for magnetic sphincter augmentation implantation and what was considered by many to be early disease. The hernias that were smaller, no visible Barrett's, A, B esophagitis, pretty normal motility, no prior surgery, and a BMI under 35. With those implantation indications, the outcomes were really in many studies based on your perspective. Was it GERD-H-Correll that reflected the patient's experience? Was it based on objective measures, the Demeester score, normalization of pH? Was it the PPI utilization rate? Was it explants? Was it dysphagia? Was it mediastinal herniation? And so you can evaluate most studies based on these particular outcomes. The outcomes with these indications in trials that had at least 12 months of follow-up, these look like this. The pivotal trial, that's the New England Journal paper that was published, Dr. Bonavina's trial, Dr. Riegler's trial, and one that was a multi-institutional study that we put together with Dr. Lipham and Dr. Taganides, but showing pretty good Demeester scores, a modest normalization of pH, a fairly standard rate of PPI utilization, a low explant rate, and some dysphagia over time. Now, recently we had accepted this past week into the Annals of Surgery the post-approval trial that was FDA mandated as part of the approval, which now shows that really pH normalization is 74% using the pH less than 4, and the Demeester score was 72.5. These are some of the best outcomes that have been proven or been shown with the Lynx device to date. But in a study that we looked at outcomes and noted that 75% of people had good to excellent outcomes with magnetic sphincter augmentation, but that left about a quarter of patients with sort of fair and poor outcomes, and so we were interested in understanding what led to a good to excellent outcome. And we identified that while most things were good, several things stood out as being negative predictors of a good outcome. BMI over 35, a structurally defective lower esophageal sphincter, an elevated lower esophageal sphincter residual pressure, and somewhere in the Hill grade classification there was a suggestion that a Hill grade 2 valve may not be as good maybe not as good a predictor, and I'm going to show you some of the details of why I think these are probably correct. As you know, with BMI, the higher the BMI, the more likely you are to have erosive esophagitis, the likely you are to have a larger hiatal hernia. So it makes sense that a BMI over 35 is potentially a negative predictive factor when you look at magnetic sphincter augmentation. This is data by Dr. Demeester's group from USC, looking at the composite Demeester score. The heavier you are, the worse the Demeester score. The heavier you are, the more likely you are to have a defective lower esophageal sphincter, all suggesting that BMI is maybe not a good idea. Lastly, this is work by Dr. Pandolfino showing that in overweight individuals, it's really the gastroesophageal pressure gradient that really is a setup for reflux disease, making it much harder when you're morbidly obese to promote reflux, making it maybe that MSA is not such a good idea. We also learned about lower esophageal sphincter and it's our ability to sort of restore a normal lower esophageal sphincter. In this study, we looked at manometrics pre and post magnetic sphincter augmentation, and we noted that if you came in with a normal lower esophageal sphincter having the LES pressure, the LES length, and the intra-abdominal pressure all within normal range, that you could largely stay normal. If you had one defect in any of these, you could normalize your lower esophageal sphincter parameters in 77%, but once you got a more defective sphincter, your likelihood of converting to a normal sphincter was only about 50%. And we knew that if you didn't convert to a normal sphincter, your likelihood of having reflux was higher. We thought this was early disease, but when you look at Dr. Lord's study and you look at if we're going to extend the indications for using magnetic sphincter augmentation with larger hernias, patients with Barrett's esophagus, the structurally defective sphincters are much more common, and so our ability to restore those sphincters may not be achievable with more advanced disease. But we know as surgeons that we have the ability to influence restoration of lower esophageal sphincter when we can restore 3 centimeters intra-abdominal esophagus, as Dr. Oschlager eloquently was just talking about, proper curl approximation. And we know from a study that we did with intraoperative manometrics that the curl closure and the Nissen fundoplication contribute differently to the reflux barrier. You can see here, after dissection of the hiatus and complete mobilization, we start to put the components together, the LES starts to show up here, and there's an additive effect after each component, curl closure plus the fundoplication, showing that both of these components add to the reflux barrier. And so that made us think a little bit about this picture and how this may influence LINC's outcomes, because if you see this, a minimal dissection approach is reasonable. In this case, LINC surgeons would repair the hiatal hernia, restore length to close the crura. But in the in-between time, the Hill grade 2 and the grade 3 valves, if we use minimal dissection here, maybe we're underestimating what's happening here. And that led us to sort of look at this. This is a snapshot taken out of the SSAT DDW abstract book for 2018, some data that we're going to show there, that looked at crura closure, proper crura closure here in the green versus the minimal dissection versus those that just had a simple suture placed versus those that had extensive dissection with no crura closure. Clearly, if you mobilize, restore length, you can achieve a much better, a much more normal Demeester score here in 80% of the patients. But again, the additive effect of having a larger hiatal hernia lessened our ability to achieve a normal Demeester score. Hopefully you'll be at DDW and we can talk a little bit more about this data then. So at this point in time, I think the data and the indications suggest that a BMI over 35 is probably correct. That's probably not a wise idea for magnetic sphincter augmentation. But what about the others? Well, this is data from Dr. Lipham's group with hernias that were larger than 3 to 7 centimeters. They had 53 patients enrolled with 3 to 7 centimeter hiatal hernias and reflux. Everybody underwent a laparoscopic hiatal hernia repair and implantation of the magnetic sphincter rather than a Nissen fundoplication. GERD H curls improved. PPI liberation was 91%. Dysphagia was about 13%. At 12-month follow-up, they published no transmediastinal herniations. At 18 months, they had a 4.5% recurrence rate, 1 at 10 and 1 at 28 months. They still had people with dysphagia. 4 or 6 of them had to be dilated to have resolution of their dysphagia. Doctors Bell and Buckley looked at 200 patients in a prospective trial, and this is their breakdown. They had about 22% that had hernias between 3 and 5. They had 49% that had hernias between 5 and 10, and then they had 29% had hernias greater than 10 centimeters with 50% of the stomach in the chest. Now, it's important to note that they used extensive mobilization here. Unlike Dr. Oschlager's vagotomy, they mobilized the vagi from top to bottom as high as they could go in 29 patients. They accepted 2 centimeters intra-abdominal esophagus. The crura were closed in different fashions with polyester sutures, but half of them had pledgets and another 83% had, whoops, go back there. 83% had bioabsorbable mesh. But what about the outcomes? Well, the outcomes in these two trials, there was no objective testing in either of these particular trials at the current time. So there's no reported normalization or Demeester scores. PPI utilization rates started to drop compared to the pivotal and Bonavina trial. The explant rate was about 4%. Dysphagia was starting to be 13 and 6%. And the mediastinal herniation in the Dr. Lipham's trial, 4.5%. Here, I think this calculation is about 8% in Dr. Bell and Buckley's trial. But what we know from data that Dr. Oschlager just showed, 4 out of 51 is 8% here in this trial at under 12 months, but there was an 8% rate of paraesophageal hernias in Dr. Oschlager's trial at 6 to 9 months too. So I think the data and the jury are still out because we don't know what's going to happen in 5 years to these particular set of patients who've undergone hiatal hernia repair with a magnetic sphincter augmentation device. There's that data there. But what about more advanced disease? What about Barrett's esophagus? What about LA class C and D esophagitis? Well, there's very little data for that. I think in the previous session, Dr. Lipham's group presented on some of the initial data on what happens to Barrett's esophagus with magnetic sphincter augmentation, but that's the only trial to date, and it accounts for about less than 1% of cases in all the trials. And so what you also know is that, as I showed you, structurally defective sphincters are more common in this group of people. The hiatal hernias are larger and the esophagus is often foreshortened, and so augmentation may not be possible. And in my opinion, currently, I think some of these cases are still more appropriate for Nissen fundoplication until more data is acquired. And what about dysmotility? Dysmotility was defined in the original FDA trial as less than 70% peristalsis and less than 35 millimeters of mercury for a distal esophageal amplitude. But the definition currently for IEM looks slightly different with less than 50% peristalsis, a DCI of 450, and we know that at least a Nissen fundoplication requires 20 to 25 millimeters of mercury. So perhaps we can extend the indications on dysmotility, but again, still no data exists for this particular area. And the problem is IEM is defined very differently. This is IEM, this is IEM, and this is IEM, and whether you'd put a links here versus the first one, I'd probably be more inclined to put a links in the first patient versus this one. But again, there's no data for defining this particular use. And what about prior esophageal and gastric surgery? Well, I think the bariatric surgeons are very, very interested in whether this will be useful here, whether they can be used in a sleeve gastrectomy or post-Roux-Y bypass patient. But again, in the post-sleeve gastrectomy patients, the sphincters are a little shorter. The sphincters have less resting pressure, so is our ability to restore these to normal, is that going to be important? I don't know the answer to that. I do know that after a sleeve, the gastric pressure is higher, and maybe that will produce more reflux, and they are also overweight to start with. And so the data remains unclear at this point in time for this particular group of people. And then here, certainly with in the sleeve patients, there's still a lot of retrograde flow of reflux. Hopefully the RELIEF study, which is ongoing in the United States at 6 centers, looking at magnetic sphincter augmentation and sleeve gastrectomy, will provide some information for that. But again, it's a small study. There's only 30 patients expected to be enrolled in these 6 centers to see if this is even feasible or not. So we'll wait the results of this particular trial in the coming years. So at this point in time, I would tell you that there's certainly some data for hiatal hernias greater than 3 centimeters. It's very early and it's it's not very mature. BMI, I certainly think, is technically off the table, and I think there needs to be further study in some of these other areas. My summary would be that magnetic sphincter augmentation functions best when implanted based on current parameters. I think many of the current outcomes of the prior outcomes have been based on a changing implantation technique, and I think now that we have a much more stable implantation technique with full dissection, reestablishment of length, I would wonder how these outcomes are going to change over the next few years. I think extension of the parameters with which we put in magnetic sphincter augmentation is continuing to be under investigation. I would like to see more data with pH outcomes and objective measures rather than simply GERD-H-Correll. And I would encourage all surgeons who are implanting magnetic sphincter augmentation that if they're extending parameters, that they should report the results, and they should certainly report their implantation technique, since we know that this has a big impact on outcome. Thank you.